an absolute pleasure to have amongst us the very prolific Dr. Sadanand Shetty, interventional cardiologist from Mumbai. Sir has been practicing for more than 40 years, an astute clinician and a teacher. Sir is the founder of CVD India and CCA International, an advisor to the Lipid Association of India, editor of many books and journals, the CSI president for the year 2020 to 2022. Sir is the chairman and managing director of Sadanand Healthy Living Center. Warm welcome to you, sir.
Thank you, Dr. Bajjan.
Dr. Shetty, we are here today to discuss something which has been here for a very long time, a class of drugs that is specifically statins. So, sir, statins have been present, what we would like to believe, for the longest time. My first question to you is that what is the relevance of statins in the management of dyslipidemia in today's scenario?
Statin is the cornerstone of dyslipidemia management, as you mentioned, for a long time. And we have seen, and a lot of evidences are favoring use of statin both in primary and secondary prevention of atherosclerotic cardiovascular disease. And our idea of using statin over the years as regarding the target dose and the what level of LDL reduction we require, these all have improved over time because of the various guidelines as well as the consensus statement. We clinicians practice in India, our own consensus statement from Lipid Association of India, wherein I am closely connected as the core committee member and the advisor. I got a lot of the important messages to give to the clinicians. First of all, whenever we talk about statin in dyslipidemia management, we have to see, one, what is the risk of the individual, like a low, moderate, high risk, very high risk, or extreme risk. And then also what is the target LDL we want. Depending upon the risk, we have to get that target level. And so also, when you talk about atherosclerotic cardiovascular disease, acute coronary syndrome, that means an acute ischemic syndrome, the target level of LDL is little different than in a chronic coronary syndrome, that is CCS. So coming back to this risk category, low and moderate risk, generally the LDL what recommended is about less than 100. In high risk, maybe around 70. Very high risk about 50. And extreme risk category, which was put by LI recently last year, wherein we have got provision to use statin to get the LDL to less than 30. So statin is a very, very useful drug, and we know that 10 milligram rosuvastatin approximately reduces the LDL by 30 milligram percent, and then by rule of 6, doubling the dose, the reduction of the LDL proportionally increase. For example, if I have to say 40 milligram rosuvastatin will reduce the LDL say to 50 to 55%, and today we have got in various combination statin available, statin alone, statin with ezetimibe, statin with the fibrates, phenofibrates, statin with antiplatelet therapy, statin with the dual antiplatelet therapy, and of late even statin, particularly rosuvastatin, is combined with the bempedoic acid. So we have come a long way in the dyslipidemia management, but statin being the oldest drug and proven drug to reduce the morbidity and mortality is the cornerstone. But statin alone is not enough today. We do need non-statin therapy, like today we are giving combination therapy of dyslipidemia management. Just like hypertension, diabetes, today we are in an era when we want to get the aggressive LDL reduction, aggressive non-HDL reduction. That means even the triglyceride component, then even the LPA component. We do use other drugs so that the target of LDL can be easily reached. So statin plus ezetimibe 10 milligram, and now bempedoic acid 180 milligram, because that has got a very strong effect in CRP reduction, almost 25 to 30%. In fact, if I have to mention two drugs which reduces the CRP, one is the statin and second the bempedoic acid. And the other advantage of bempedoic acid is additional triglyceride reduction, additional ApoB reduction, which are also important just like LDL. So clinicians of India should follow the consensus statement which is pertaining to our country, because our dyslipidemia is not the same as the Western dyslipidemia. Totally going back to the European or the ACC guideline, since the Caucasians dyslipidemia and our dyslipidemia are a little different. What way it is different? What is called as an atherogenic dyslipidemia. We have high triglyceride, increased small dense LDL, and we have low HDL. Looking at that scenario, just eating the LDL alone by maximum or high intensity statin dose is not enough. So we have to target the other factors also. Therefore, our consensus of lipidase in India has given a very clear, the target, like what target as a primary target, LDL target. Then co-primary target. What do you mean by co-primary target? What is called as a non-HDL. That means measure total cholesterol minus HDL is a non-HDL cholesterol. This non-HDL cholesterol includes all bad cholesterol, LDL, IDL, VLDL, LPA. So we have to get to that goal. Just getting LDL to 50, 60, 70, depending upon the risk is not enough, but we have to get into the other non-HDL risks also, and also if possible the ApoB. These are the additional target what we must achieve in here. Unlike the Western guideline mentions triglyceride, though it does have a role in atherosclerosis, they are not giving us a very clear cut what level of triglyceride we should reduce. But my personal opinion, and being a co-author of many consensus statement of lipid association, we have in a very, very important role to perpetuate this knowledge, to our physician. So how Indian dyslipidemia clinician in India should treat dyslipidemia in a different way than the Western, because our atherosclerotic cardiovascular disease is premature, at least by 10 years. We do see people at the young age, almost 20% myocardial infarction, less than 40 and all. And therefore we have to be very aggressive right from the early part of our life. It is not just you are starting statin at the age of 35, 40. Strong family history, we have multiple risk factor. You may get the lipid profile even at the age of 18 years. In fact, our recommendation is to get one lipid profile at the age of 18, 20 and then act upon that. Earlier the statin you use, the dose requirement is less, and the lower the LDL you achieve, better is the efficacy. Therefore we say lower is the better, start early, the dose requirement also early, and there are primary prevention study available today telling us if you reduce the LDL and the other lipid factors early in the age, the legacy effect remains even at the later age, just like hypertension, diabetes. Now APCAP and TAXCAP, primary prevention long study, almost the follow-up of 20 to 25 years has shown clearly that you have reduced the LDL and the other lipid factors in the early stage, the legacy effect or the positive effect of that is maintained. So this is another area where we have to perpetuate our knowledge into practice.
So I really appreciate the inputs as well as the insights over all of this. My final question would be, with statins there could be some limitations in terms of side effects which literature cites. My question to you is that how relevant are these clinically and in real life scenarios?
I agree with you, Bachani, totally, because we cannot say statin is like a placebo-like drug. There are side effects. Some patients just can't tolerate statin. Though the literature says up to 5%, 5 to 10% incidence of statin intolerance, and intolerance may be just a muscle pain, maybe myositis, myopathy, maybe rhabdomyolysis of various degrees and all. But sometimes patient, even if we do the enzymes, CPK may not have gone very high, but they just can't tolerate because of severe muscle pain, etc. So today we have to believe that statin intolerance is an entity, though many times in the meeting I hear from our colleagues that it is a myth and all, there is nothing like statin intolerance, which I don't agree. However, the recommendation for doing the enzymes, muscle enzymes and all is there when you have got these symptoms, whether the CPK is elevated more than 3 to 5 from the baseline, or whether more than 10 times like in what you get in rhabdomyolysis with the increased creatinine, etc. And that situation we have to stop, maybe give a challenge with a small dose, wait for a few days and go slow, and maybe the potent statin you may hold and you may go into the little lower potent this statin. Like rosuvastatin is called in a superstatin, or they are very potent statin, and the other statin are supposed to be less. You can change the statin to a different different type, like rosuvastatin you can change over to atorvastatin. You can start with a small dose, build up the dose, and then many times patient can tolerate. But today we have got a good molecule, that is bempedoic acid, which is particularly for statin intolerance patient, because the ACL enzymes is not there in the muscle, and therefore it affects only the reduction of the cholesterol in the liver. It is the same pathway as what we see in the statin, one step before the statin, and therefore the effect on the muscle is not there. So also when you use statin like rosuvastatin, which are more like the fat soluble one, then it will be more penetrating into the muscle, more symptoms like that. So basically bempedoic acid today, particularly with the combination of the statin, when statin can be tolerated, like a maximum intensity, high intensity 40 milligram, 180 bempedoic is available to us. But people who cannot tolerate the higher dose, to minimize the side effect of that, we can start 10 to 20 milligram of rosuvastatin with bempedoic acid. So personally I feel bempedoic acid is in use abroad for last more than 2 years. Now DCJ approval is there, and people who cannot tolerate statin at all, we can use bempedoic with ezetimibe alone, or we can use small dose of statin, maybe 10 milligram of rosuvastatin, 20 milligram. In fact, the effect will be better. And this combination of 2 or 3, like today is a era of combo therapy, like rosuvastatin, ezetimibe, rosuvastatin 10 to 20, ezetimibe 10, and bempedoic 180. Maybe a combination of the future, which will get down to LDL around 60 to 70%, and that will be almost like a poor man's PCSK inhibitor. So I see this new drug as a new indication, not like a new indication we are creating, but what limitation we had with statin we are overcoming, and we can better treat the patient of the dyslipidemia.